And I wish we had better pictures on this. This is a case where we had a million pictures and our image server went down and just, but it's a good case, so you're gonna do it anyway, even though the pictures aren't great. All right, Vishnu, you're up.
Nice to meet everyone. I'm Vishnu, one of the PGY3 residents. Hi, Vishnu.
Pleasure to meet you.
So for the first case, we have a 67-year-old female complaining of hazy vision in the right eye for about 5 days. Pathology history includes diabetes type 2, hypercholesterolemia. She's on a few medications as well, metformin, Crestor, Bactrim, valcyclovir, probiotic syndrome. She has the vision in her right eye is 20/40 and vision in her left eye is 20/20. IOP is within normal limits. And the slit lamp exam is significant for trace anterior chamber cell and vitreous cell in the right eye.
Okay, so color from this photo of the right eye, media looks hazy. The nerve, honestly, kind of hard to make out. Like I don't really see like a sharp border. I'd say the vessels are attenuated. And then I'm also drawn to these kind of areas of like hypopigmentation superiorly here, and then also inferiorly here, kind of look like little white dots. Macula looks grossly normal, maybe some like hypopigmentation that might be like edema, like a blunted reflex, but do we have like another
That's
photo?
very good. Yep. So this is the same eye.
So the same eye looking more nasally here in the periphery and seeing more of these white lesions, kind of like varied sizes. Some are smaller, and then we kind of have this bigger lesion over here. This is kind of a medium size. I would say like the margins are pretty blurred with them too.
Good. Elevated, are they much elevated?
They don't really look elevated to me. Like,
And
if I
can
look
you
at the
tell what
vessel
layer
here,
that's, yeah,
It looks flat over it.
and we'd be under the, if you see the vessel, does that mean it's Under
So
the-
it's subretinal.
intraretinal or subretinal? Under the vessel.
I think we have another photo here as well.
Pretty much the same I'm seeing here. It's not very much, it's just kind of extension all the way out to the periphery.
Those vessels overlying that white part.
This one here?
Yeah, right there. Do those appear a little white? Possibly.
Yeah, like it looks attenuated, maybe like. I don't know the term
Almost
for
like
it,
vaso-occlusion.
but yeah,
arteriolitis.
like part of a vessel is almost like missing, like right there.
Very good.
Okay, so this is a fundus photo of the left eye. Media looks clear in this eye, nerve looks sharp and pink. Vessels relatively normal caliber. There's kind of this maybe hypopigmented area over here in the periphery that might be, it's like a nevus. Macula looks grossly normal.
And there you can see the nerve looks nice and sharp, you know, the
Yeah.
other one you were saying.
Yeah, and then there's maybe like these two areas of like kind of those whitish spots there. I'm not sure if that's significant. She wasn't having any
Probably more.
changes in vision. So this is an OCT of the right eye. Vitreous definitely looks hazy here. And I mean, there's good foveal contour, a little bit diminished. The layers look pretty well organized. I don't see any like subretinal or intraretinal fluid. Maybe these kind of areas here, hyperreflectivity.
Those are probably vessels.
Vessel.
That white snow vitreous, that's just a gain setting. Don't let
Okay.
that mess you up, because that's just how dialing in the camera, maybe because it was hard to get through, but there are some spots. I mean, there are some star, yeah. So
Yeah.
those count. I wouldn't read the snow though. And then if you look on the surface of the retina, sometimes you see those spots, you can look on the surface and maybe pick out those little bumps.
Right here.
Could be little inflammatory deposits on the surface.
Is there type of platelet or is it just a cut?
It's probably the cut. I'd want a raster to do that. It might, yeah, so yeah, that's a left.
So this is the left eye now, okay, yeah, so same thing here, probably just the camera. Oh, good foveal contour, layers are well organized, no fluid, overall looks pretty healthy.
And that's all, with we had fluorescein, I had like a year follow-up and it's all just gone.
This patient, hazy vision 5 days, trace AC cell, moderate vitreous cell. I think those some of those hyperreflective deposits might have been vitreous cell maybe on the OCT. Cream white colored retinal lesions, primarily in the nasal periphery, arteriolitis. Some optic disc edema as well. Is any idea of a differential for this patient?
Yeah, so I'm thinking like higher level differential would be like one of the white dot syndromes. And then also would consider like something infectious, maybe like sarcoid or TB with that, with kind of the arteriolitis around those vessels. And then also would consider like metastasis, like a mass, especially with that area peripherally that was pretty large. And then I don't know, maybe like a neuroretinitis with the nerve being destroyed.
So for retinal whitening, okay, go ahead.
So a few things on the differential, like dot syndrome, like you said. Could be PORN and CMV retinitis, since you have retinal whitening with vitritis over it. Toxoplasma, or the cause of optic neuritis, like you mentioned, syphilis. You have a masquerading symptom, leukemia, lymphoma, Behçet's disease, sarcoid, BKH, ocular ischemic syndrome. So for this patient, some more tests were done.
Yeah, of those, which are the scariest? That's what sometimes we start the
Oh, yeah,
treatment.
that's
Yeah, when you look, so, because you can't really tell. I'll tell you from a retina standpoint, top of the view is the herpetics. Because you've got the top of the list is herpetics, so you got retinal whitening and vasculitis. Then it could be toxo, and it could be a syphilite. It could be, it's not really the white spots, because the white spots, when you look at that posterior, the macular picture with the white spots, those can be white spots. Once you get the confluent, really none of the white dots seem to do that. Like, I guess ampy maybe, but you don't get ampy in the periphery. So anytime you see uveitis, retinal whitening, the top 3 diagnoses in your head should be toxo, because it's toxo super common. But then the scary one is one of the herpetic, because then the eye goes, while you're trying to figure it out, the eye goes blind. So a lot of times you end up covering the herpetic while you're thinking about it.
And she was on Valtrex, I believe, right? Like the medical history didn't really say history of.
The 1 gram, yeah. No, that was probably started after this. I think that was all started. So that's what you would do. Sorry, that was a later visit. Yeah, so what they were doing there is covering for herpes, covering for toxo when you're doing the test.
Yeah, I was wondering why she was on spectrum.
Yeah,
Behçet's disease is a mean one too.
yeah, oh gosh, yeah. All right, so keep going.
So for this patient, some tests were ran for some infectious causes. The only thing positive was a toxo IgG on that part, but that's indicates a past infection of toxo. The IgM was negative. An AC sample was taken, and the patient initially was treated with Bactrim, Valtrex, Pred, and Cyclo. However, when the lab resulted, the Bactrim was stopped and the patient was tapered off topical therapy, and then the Valtrex was bumped up to 1 gram 3 times a day. Wait, no, so 2 was 1 gram. Okay. Reduced to 1 gram. 3 times a day. So some of the anterior chamber paracentesis lab work, so they tested for CMV, HSV, 1 was negative. It was significant for VZV, which was positive, indicating it was, RN associated VZV.
The PCR test or something?
Yeah. Getting better at those. They're getting easier and easier to get. And the thing is the sample size, because you do an AC tat. So they mostly will do, you have to get about 0.2. Yeah, they want about 0.5, 0.05 per test. And if you're gonna run the 4, if you're gonna do toxo and the BZV, HSV, HSV, and CMV, then you need 5, so you need 0.25, which is a lot. But if you're patient, you can, so what you do is you tap the anterior chamber and then you just sit there and like hum to yourself, because it'll start to collapse. And then you pull a little more and then you wait a little bit, pull a little more. And if you take your time, sometimes it'll just collapse. And then what you can always do is go back, wait 2 minutes and tap more. But sometimes if you go slow, you can get, I mean, I've gotten 0.3 or 0.4 in some of my RD patients at
Wow.
BNC, just by going like slow. But, and then you send it off.
Take me home for I'll be back. For temperature, what I was told, like VZV, HSV are both easier to get toxins to send out, and they require a little more from us for that one specifically.
So do you not test the docs?
We do.
Yeah.
I feel like for like, I guess because when I'm tapping for like R rule out or whatever, then we're really just doing like BCB, just
Yeah.
BCMV.
I suspicion.
But yeah, I haven't had anyone that's I suspicion toxic, so
Okay.
I've never had to.
I see two toxins so far.
You have? Wow.
So, acute retinal necrosis is a rapidly progressive necrotizing retinitis. And it's characterized by a triad of retinitis, vitritis, and arteriolitis. Typically caused by most associated viruses are the VZV, HSV1, and HSV2. However, there have been case reports of CMV, EVV, HSV6 as well associated with it. And specifically, like VZV, HSV1 tends to be more associated with a little older, like around 40 years of age, whereas HSV2 tends to affect younger people, less than 25 years old. However, overall, ARN tends to affect people in their 5th to 7th decade of life. Most commonly healthy immunocompetent patients in adults, however, they don't necessarily have to be immunocompetent. I'll talk a little bit more about the diagnosis. The diagnosis is independent of the viral etiology and independent of their immune status. Typically, it can occur after a patient has like an acute, fulminant systemic disease within months to years after it, or more acutely after a more isolated, cutaneous disease of more cutaneous herpetic disease as well. There's no specific association with gender or racial association, and it's very rare, 0.5 to 0.63 cases per million per year. Some signs and symptoms, they can have photophobia, decrease or loss of vision, typically unilateral, floaters, flashing lights. And the second eye will get involved in about 36% of cases. They say around within 6 weeks typically. They can present with episcleritis, so they present with inflammation essentially. Episcleritis, scleritis, corneal edema, they have KP's anterior chamber inflammation, vitreous cell, and again, the retinitis, arteriolitis. And specifically for the diagnosis, so the diagnosis, again, it's a clinical diagnosis, not based on the viral etiology, not based on the immune status of the patient. And the American Uveitis Association or Society has specific criteria in terms of how to diagnose acute retinal necrosis. And it's starting in the periphery, one or more foci of retinal necrosis with discrete borders, can be scalped borders. And having macular lesions does not rule out that you can have macular lesions, but you need the peripheral lesions to meet this criteria. It rapidly progresses in the absence of antiviral treatment, typically spreads circumferentially and eventually coalesces together. You have occlusive vasculopathy affecting the arterioles, vitritis or anterior chamber inflammation. You can have optic neuropathy or atrophy, scleritis and pain, but these are supportive features, but not required for the diagnosis of ARN. And for the pathology, it's split typically into 2 phases. There's an acute herpetic phase, can last around 4 to 12 weeks, where you have viral particles in the retina and the vitreous, creating an intense inflammatory response, which is why you have that retinitis, the dense vitritis as well. Plasma cells and lymphocytes are recruited. And the inflammation in the retinal arterioles causes vaso-occlusion, leading to that, ischemic retinal necrosis that you see in the periphery and the downstream retinal tissue. Eventually it becomes more of a late phase, more late cicatricial phase, where there is deorganization and organizational degenerative changes in the retina. And that leads to late complications. I'll talk about the complications more, but there's a very high rate of retinal detachments, posterior vitreous retinopathy as well. So for the testing and workup, the anterior chamber tap has become the primary method of diagnosis nowadays. It's very sensitive and specific. The PCR is very sensitive and specific, 95% specific and sensitive and 97% specific in detecting the viral etiology. It has replaced, viral cultures that they used to do. However, if you have a case that's high suspicion for RN and your PCR is negative, the BCSC does mention, IVP mentions as well that you can consider a retinal biopsy if you're unable to diagnose the cause. You can also consider fluorescein angiography and OCT to help with your diagnosis. You may have, filling defects within the arteries and the periphery, and OCT you can see, OCT can be used to monitor, for intraretinal fluid. You'll typically see like very hyperreflective retina, typically starting with the inner retina and eventually the full thickness of the retina as it progresses to a full thickness retinal necrosis. And ARN is, kind of fits into, there's other viruses that can, devastate the retina. There's ARN, there's progressive outer retinal necrosis, and there's also CMV retinitis. And it is a little important to be able to differentiate these. Like I mentioned before, ARN typically starts peripherally, with associated vitritis, arteriolitis, progressive outer retinal necrosis, more likely in immunosuppressed patients. It's rapidly progressive retinal necrosis, looking more like retinal whitening, usually in the absence of vitritis. And CMV retinitis is more of a pizza appearance, is what they say. Or pizza pie appearance.
But the RN and PORN commonly BCV, right?
Yeah, 2/3 of the patient are.
Yeah, but it's the same virus, different. Yeah,
Can it be a different virus? You said 2/3 are VZV, right?
For others, yeah. But
Well,
the diagnosis is independent of the virus itself.
Right.
CMV presents like a brush fire appearance with retinal, hemorrhages and exudates along.
CMV is much less aggressive. It can present late, but it goes very slowly, usually. PORN have you seen PORN?
Like once or twice, I think.
I once put up a case on a website I was running. I got so many hits, it was unbelievable.
Oliver did that one time. I remember he was telling me that he was sitting in front of a patient, he was gonna show them, oh, this is what you have, and it wasn't good. Poor sweet Oliver.
But it is a devastating disease.
Yeah.
Usually the prognosis for life is terrible. Yeah, so, but it's still miserable. It's a matter of 2 weeks they're gone. It's over.
So for treatment, we want to treat them with systemic antiviral therapy, based on, getting the PCR result, what the diagnosis is, HSV, VZV, you want to treat with systemic, acyclovir, or sorry, valcyclovir, acyclovir, or oral valcyclovir. For CMV, you want to treat with valganciclovir or ganciclovir. Studies have shown similar bioavailability between oral and IV treatment. And this can be, you can also consider intravitreal injections as well as supportive in conjunction with systemic treatment. But specifically, if it's closer to the macula or optic nerve, if you have optic nerve edema, then you're much more likely lean towards doing intravitreal injections as well. I know every provider has a little different in terms of, I feel like, how they when they want to consider intravitreal injections for these patients. I also saw on the BCSC on the table that they used to have like a ganciclovir implant, but it's not available anymore. I don't know if
Yes,
that's-
yeah, that's on the market.
Aside from the systemic and intravitreal injections of antiviral medications, you want to start them on topical steroids and cycloplegics. You can also consider systemic steroids after 24 to 48 hours when you either start to see some improvement or after, you're treating it. I've seen some patients where I feel like it's hard to know if they're responding just because they have such a dense vitritis. So I wonder, if you have like a PCR positive, VZV, HSV, you're treating with antiviral therapy.
Yeah, if there was a dense vitritis, I would probably follow up with steroids pretty quickly, because the idea is to get the vitritis out.
Yeah, but the vitritis also generates, I think increases the risk of retinal.
Yeah, detachment, yeah, the vitritis.
So you really want to get that, yeah.
In some of these diseases, I love posterior subtenile catalog, I do it constantly, but you can't take it back. But some of these diseases, you just do oral steroids, if you're unsure, if you can stop them.
You can also consider prophylactic laser barrier laser typically, so there's a very high rate of retinal detachment, high 75%. And typically there will be retinal breaks at the border between the healthy and unhealthy retina. And I've always heard it's controversial whether you should do a barricade laser around those areas of an unhealthy laser.
Yeah, when I came out, it was like malpractice not to do it, like you had to do it. And now there's some papers saying it doesn't, it's such a rare disease, like you say, so some people, do you guys do it here?
Laser.
Yeah, RNs?
I've seen patients in the.
They're usually here when they're in their acute phase, so when they're here, it's because they need to tap and inject and IV
And then they go elsewhere.
antivirals, and then they go to clinics. I don't actually remember what they do.
I know there's a patient who he follows that had barrier laser done.
Right.
They
Yeah, not for CMV, it's interesting, you went barrier laser, but for RN, you would barrier laser, I don't know, if that was my eye. The thing about barrier lasers, it tends to be kind of posterior, because you're going behind the lesions, and of all the retinas I've had the most trouble fixing, it's the ones where there's a bunch of posterior laser.
Because then you've already
It's
shown
all
your wall.
stuck, yeah, because if the retina detaches, basically, reattaching a retina is kind of like fluffing your sheets. So you kind of want to fluff it, spread it out and lay it back, and every laser spot gets in the way of that.
Yeah.
So those are all little tacks that are keeping you from getting the retina where you want it. So I probably would not want it if I had it on now for myself. Because you can fix, the other thing is, we're better at fixing things. Oil, laser, perfluoron, things have gone pretty far. And I think there's some papers suggesting you shouldn't necessarily do it. It's
I
pain in the neck.
think it was, Heyman was big on that.
Yeah, it goes way back.
Yeah, so before we had a lot of the tools, we have them.
RN is a very devastating disease where patients often have visual acuity 220 of 2200 or worse. Often having retinal tears or holes, the border of the healthy and unhealthy retina. Also retinal detachments are caused to the PVR, causing retinal traction. That's a component of the retinal detachments as well. Patients can have vitreous hemorrhage, macular pucker, optic neuropathy, and atrophy. And patients can also, have encephalitis and meningitis from, the virus. I believe it's HSV2 that's a higher rate of association with encephalitis and meningitis. But that's just a warning sign, because if they begin to experience that, it can be a sign that it might be progressing to the other eye, or it could progress to the other eye as well.
Yeah, the main thing is diagnosing it and treating it to protect the other. One of the worst cases I saw in my life was I'd just gotten into practice. When I started in 95, the HMOs were really pushing in then. And so they're sort of coming back a little more now. And there was this treatment trial philosophy where you didn't use specialists. It was an anti-specialist thing. And so what you would do is you would see a patient, you're not sure what they have, you treat them for a while, and then you're like, okay, this is beyond I should send them out to the specialist. So I saw a patient who had bilateral acute retinal necrosis. It was someone who just kind of been watching for a while. They thought maybe it was spout. And it was, when I saw it, and I don't know what it looked like initially, it wasn't white, it was mostly hemorrhagic. So, I mean, that's the thing, they always look, these are hard diagnoses. So sometimes they're like, oh, now you see it's arm. Sometimes it looked kind of funny, maybe a little more vitritis, not much whitening, maybe a little more hemorrhage. So they didn't send it. By the time I got the patient, there was, one of the eyes was LP, and the other eye was maybe 2200. But you could see that the retinitis had gone everywhere. So we put the patient in the hospital, put them on IVs, and they were NLP in both eyes. In almost no time, from a treatable thing. So,
The vasculitis is given right here.
yeah, this one's a nice picture. That's why I want.
But
I wish we had all the
that,
pictures.
yeah, okay.
And the white spots are, once you get the confluent white spots like that, and multifocal, I mean, toxo, it would be weird for toxo. Toxo could do this. The only thing that this could absolutely be is lymphoma. You know, that could totally be a lymphoma eye. And so that's the hard part. And that's why if you get stuck and you don't need a biopsy eventually, the lymphoma can look exactly like that. But yeah,
Couple questions. If you saw the association of, arm showing up temporarily with the exhaustive outbreak. No, when you're preparing. Because we get consulted all the time, like this person's got.
I thought that was more likely to be somebody immunocompromised.
What
Is it more likely that they have both at the same time, they could have HIV?
Well, sure, but I'm just saying, somebody's got a zoster outbreak on their face and we have to rush in at 2 a.m. to see if they have PORN.
Oh, how often do they harm? Oh my gosh, like almost never.
For me, 0.
Yeah, I've never
seen it.
once seen it.
The other thing you mentioned, the therapies, is I think Culbertson showed that if you keep them on prophylaxis for over a year, I have patients that, I followed for 5 years, but I always kept them on it,
Mhm.
so they don't get a recurrence. And the other thing that's interesting is, now we have a vaccine. You
Right.
get the vaccine?
Yeah, got the new one.
Yeah.
There's a
and,
dog that worked.
It might be interesting to, does the vaccine protect? And
Yeah.
how would you get that data? But it should be available, because there's probably a significant portion of the population, i.e. Robert Kennedy type, that don't get vaccines. And so, what's the history of vaccine history in these
I
patients?
mean, I think even with herpes corneal lesions, you rarely get ARN. ARN is just so uncommon.
Yeah.
So the idea of rushing in to check somebody for ARN
Ormerod,
just seems like.
who was on staff here for a while, he did a review. I think it's common to have a history of a herpetic
Right.
lesion, but it's not
Have
simultaneous.
something in, like, that's so far.
Yeah.
Yeah, it's like so.
Even like ulcers, like the most horrible ulcers, like the amount that also have any kind of endophthalmitis, like anything remote, like close to endophthalmitis is so low also, even the worst ulcers.
Yeah, the eye's pretty protected. All right.